Thanks, everyone. It's great to be here. Thank you for the organizers for inviting me to speak here today. It's a real honor always to be back at ASAP. I wouldn't miss this, just in the midst of the move, and I apologize for coming in just today and having to leave, but it's really a great conference because of the focus on education is something is really special and very hard to get at many of the conferences that I go to throughout the year. This is a tough topic. You know, this is a challenge that I face in the clinic every day, and I'm sure the other speakers here do as well. Very difficult to tease these two disorders out, and it's becoming harder and harder with time. It's not becoming easier. The more tools we develop, the more interesting things and fancy imaging we get, it's confusing the picture even more and more. So this is a difficult topic to wrap up in a very short period of time. And I'm not sure how many of you know what pseudotumor is, but pseudotumor, doesn't have a whole lot to do with tumor anymore. It's something that is really an elevated pressure. It's a pressure without hydrocephalus, which is a common thing you can see with Chiari, more likely from Chiari 2, right, instead of Chiari 1, which is much rarer to see hydrocephalus. But this is not hydrocephalus, what we're talking about here. There's no mass, there's no tumor, there's no obstruction. The imaging, in fact, looks quite normal, except those ventricles, the spinal fluid space in the brain, if anything, are tinier. They're even stiffer and smaller in this condition. And it can be picked up, usually, many different ways. They may present with headache, visual problems, blurriness of vision, papilledema, which is elevated the optic discs to cause swelling of the eye, which can lead to vision loss. So you can go blind with papilledema. This is a very serious condition which requires very frequent visual exams. Or you can just have headaches and elevated pressures, and we know now that the eyes can look just fine. And your spinal pressures from a spinal tap can be in the 30s and 40s, sometimes even 50s, and your eyes look just fine. So the eye is usually, we think, the window of the brain, and in a child it's a very good marker, but in adults it's not panning out as much as we thought. So the diagnosis is really a clinical diagnosis. It's a diagnosis of exclusion. There's no other reasons for why this is occurring. Sometimes there's a problem we find with the veins, that you don't drain as much from the venous side. You may have an obstruction in the veins. Sometimes you can pick that up on CT or MRI imaging, but most often I check for that, it's usually just fine. So this is usually idiopathic, meaning no known cause, and diagnosis of exclusion, okay? And interestingly, on the bottom here, there's a subset of these patients, more likely than you'd expect, that have low-lying tonsils. Well, that's interesting. So maybe these two are related in some way. Dr. Mayer must have talked to you earlier at this conference about the natural history and findings on imaging you'd pick up, in 20,000 people, how many would have a Chiari malformation. It's pretty low percent, and many of those are asymptomatic. But here's this group of pseudotumor patients, and more likely they're going to have this to 6-7% as opposed to much lower. So this is a much higher incidence that they may be related more than we think. The symptoms overlap tremendously, and from my military days, I talk a lot about traumatic brain injury and post-traumatic stress, and it's almost the same slide issue that we have this overlap, and what are we going to do with all that? We have headaches. They may be frontal or occipital, right? With Chiari, you may not always have that classic presentation. It may not always be aggravated by Valsalva, but in pseudotumor, it's a similar type symptom. A lot of neck pain, visual changes. It can be blurriness of vision, seeing spots. The nystagmus is more specific to Chiari, but the global visual change can be pseudotumor, Chiari, really hard to tease that apart. Dizziness and vertigo, very, very common, as you know, in both. And in pseudotumor patients, they can tell if they're good at this and they've been at this for a while, if their pressure is high or low and, or right on the money. They can tell just from their dizziness and vertigo symptoms. So very difficult to tease this apart. You can have paresthesias in both. If your pressure's up, you may have some tingling of your arms and legs. Chiari, as you know, has the same, or Syringomyelia. Positional symptoms, it's worth paying attention to, particularly with low pressure. You got to be careful if every time you sit up, you're getting symptoms. If your headaches are so much worse upright versus sitting, is there some positional component? It's worth asking because they may still do well in your treatment, but they may have trouble later, and you wish you would have asked that early on. Now, hydrocephalus, I'm not sure how much you've talked about, just a couple slides that, it's rare with Chiari 1, but you don't want to miss this because the treatment may be very different. And this is where you may have an obstruction, at that craniocervical junction. And we still have to make that decision with hydrocephalus patients. Are they symptomatic from the Chiari or the hydrocephalus? Are we going to shunt them? Are we going to do a decompression? We know that their Chiari, looking at the back of the brain, is going to look better and better. With a shunt, it's going to have a dramatic change in their morphology. Will their symptoms dramatically disappear? May or may not. But with global hydrocephalus and a Chiari and symptoms, we would usually shunt that patient. But we have to be careful. There's hydrocephalus, and then there's patients that are just fine, but their ventricles are a little larger. That's a different patient. That's ventriculomegaly. So they may not be symptomatic from their hydrocephalus, and as a pediatric neurosurgeon, we really try to limit the amount of shunts in the world as much as we can. One more shunt is just another shunt that could go wrong, and shunts is a lifelong commitment. It's a lifelong venture that you have to be willing to entertain. So here's a case of a 17-year-old woman this year we treated, progressive weakness of her arms and legs over 6 weeks, rapid, very rapid worsening of this uro. She couldn't even eat, she couldn't walk, but she had a long history of headaches. You start asking her more questions. She had a shunt, placed at 6 weeks of age, very little follow-up, no revisions. Outside hospital, treated for this condition. I'm not sure if you ever heard of Guillain-Barré, but that's where there's an attack on the immune system. Treated for that, didn't get better. Finally had an MRI scan, which was dramatic. Hydrocephalus, very tight foramen magnum. So this is the real thing. Okay, this is not pseudotumor. This is hydrocephalus. The shunt went bad. Her spinal cord was completely white, which they read as swelling of the spinal cord, but it was really, I think, a syrinx. We revised her shunt. She had rapid improvement of her symptoms. Within a week, she was walking, went home, eating, doing very well. But why did she get in trouble so quickly, with such a long history? And her imaging, even a week out, looked so much better. She's young, 17, and she's been doing well and getting better and better ever since. I'm going to show you about 6 cases as I go through, and they're all going to be a little bit different. But so this is hydrocephalus. We have a shunt. We can deal with that, and this is not pseudotumor. Another kid, 11-year-old, with occipital headaches, okay, more classic Chiari-type symptoms, a lot of tingling in his arms and legs, okay, very common scenario. He does have some horizontal nystagmus, swallowing difficulties. This sounds much more like a Chiari than a pseudotumor kid, to me. Visual exam, normal, okay? Very tight Chiari, so it looks very straightforward. Ventricles, not small, but we would not call this necessarily hydrocephalus, just a little bit larger than normal, okay? And he actually had some old films we saw 4 years before this. They were the same size. So we're not thinking maybe rush to a shunt, but when we decompress this kid, you've got to be careful. The spinal fluid issues may haunt us, so we have to be monitoring that potentially. He had a small syrinx, which did resolve, and he had a decompression we did, never had to shunt him. He's now about 3 years out. So you can get away with it, and we really try to avoid that shunt if we can. Versus pseudotumor, which the imaging might be just fine, may or may not have a Chiari, but of course in this talk we're talking more about the patient with Chiari and pseudotumor. That's a very difficult challenge that we have to face. That's the battle that we're talking about here and what we're going to treat. But these people can have quite a bit of double vision. The enlarged blind spot we're worried about in their vision. They can go blind. Medically, there is some treatment. They can have Diamox. Okay, Diamox, if you're a climber, any climbers here? We're climbing the mountains. You're going to take Diamox to prevent the altitude sickness. Fairly well tolerated, but at the doses we probably need to meet this and make them feel better, they're pretty high doses. And we're pushing close to 2,000 a day. These are very high doses of Diamox, which you're going to have some side effects on. Some of the same side effects that would maybe present as a Chiari malformation. So then it becomes dirtier to tell the difference of Chiari versus pseudotumor. They may be on Lasix, diuretics. They may have had steroids coming on or coming off. So we have some medical treatment which we would always try before a shunt if we can. If it's just a vision thing, we might decompress their optic nerves. That's something not I do, but the ophthalmologist would do. A shunt, they may need a shunt. Their symptoms are refractory to any medical therapy. Every time we tap them, their pressures are high, maybe in the 30s. And I really try to tap people at least a few times to make sure that they have a good response to that. Some do lumbar drain trials. There's other ways to tease that out, which I can't get into today. We talked about this at last year's ASAP meeting, whether there's a role for endoscopic third ventriculostomy. If you can divert the CSF under the brain into the subarachnoid space, will that be enough, without shunting that patient? People who are symptomatic from the Chiari, small ventricles, pseudotumor picture, you do the endoscopic third ventriculostomy, a lot of their symptoms have resolved. There's good literature on that, and we presented that last year, if any of you were there. And then we start getting papers like this coming out. Papilledema is the sole feature of Chiari malformation presenting. Well, they didn't present and say, Doc, I have papilledema. They must have had other things going on, so this may not be the whole story, right? But this is a problem because that means eye swelling alone, and if you read this case report, there's really no other symptoms. Is that enough? And is that truly from the Chiari, or is this something related to pseudotumor? There's a quiz at the end, so make sure you get all this right. And what's the relationship? Is it just pure coincidence? That these two are somehow related to each other? Is it causal? Is the Chiari then causing the pseudotumor problems, or vice versa? What's getting them into trouble? Why are they all of a sudden over that edge and having symptoms? This is probably not a brand new finding, but why are they getting into trouble? Is there a block? Well, might be, but then you fix the Chiari, there's no block anymore, but they still have pseudotumor. So that doesn't quite fit, right? We don't usually tap people with the Chiari. Tight Chiari malformation, we're not going to do a lot of spinal taps. We're so worried they're going to get worse, right? So we're difficult to diagnose this before the decompression. At Duke, I must say, we've been doing this a bit more with very tiny, the baby needles with a CT-guided tap, which, at least doesn't get that big hole. And you may tease out a little bit more what's going on. But does it even matter, is the question. What is the true association between these two? So another case, it's an 8-year-old. It's going to get more complicated here, so pay attention. 8-year-old with frontal headaches, okay? Not as classic occipital, frontal headaches, multiple medications, 6 different medications, amitriptyline, Topamax. The speaker before presented those beautifully. Even biofeedback she had. Normal exam, eye exam, normal. This is her imaging. Very tight Chiari. I don't know if you can see that. Very tight, no syrinx. Now, she had a decompression. She did beautifully for 2 years, just fantastic. Totally just back to everything. 2 years later, symptoms recurred. Well, why did that happen? Her imaging looks fantastic. So what do? We bring her back. We repeat all the studies. They look great. But she's still having a lot more symptoms again. A lot of frontal headache, which completely went away with the decompression for 2 years. How do we explain that? Well, we measure her pressure. Her pressures are in the 30s. When did that come up? Her pressures are now 30. We bring it down to 15 or 20. Her symptoms go away. Headaches resolve for a couple of weeks, and they come back. We tap her again. The same thing happens. We put her on Diamox. Not bad, but not perfect. Not back to where she was. But we have a lot of patients like that, and these are our failures. These are people who the imaging looks great. You feel so good early on, but they come back and they have problems. And it's not a nice story then. Now we have a problem of a chronic disease of how are we going to fix this? Sorry, did I? So this kid, 9-year-old with headaches up on top. So again, not that easy, not even frontal, not occipital, vertex, okay? A lot of these kids just say, it hurts right here, right on top of my head. But a lot of blurry vision in this kid. and the ophthalmologists are telling us her eyes are swollen, okay? But she's got otherwise a normal exam. It may be hard to see, but she's got a 14 millimeter Chiari, tight-looking Chiari, okay? Not one of these soft calls where the CSF flow may be abnormal, mild descent of the tonsils. No, she's got a real Chiari, but her vision's going bad, and it's getting worse. What are we going to do with her? Okay? What are the options? Well, here's her ventricles. No hydrocephalus. In fact, tiny ventricles, right? These are really small. Okay? So we put a monitor in her brain because they're so worried about these pressures. Intracranial pressure monitors, if you know what those are, little tiny things will do. Looks like antennas sticking out. They're not that fun because most of the patients are very bored just sitting around watching these pressures, but they're keeping a very close diary. Her ICPs are 1 to 2. Now, how do you explain that? Blurry vision, I told you this is from an intracranial hypertension, high pressure situation, but her ICPs are normal. Okay? Well, we ended up fixing her Chiari because we were so worried about how tight it was and how her vision was getting worse. Within 24 hours, her vision immediately was restored back to normal, where she could see color again. I mean, she was losing color. I remember I was in the Air Force when you go in this hypoxic chamber where you lose all the color, and it's a very scary feeling, but she described the same thing as you go back to oxygen, where everything just came back to normal within 24 hours. And the papilledema resolved by 6 weeks. So that seems very causal. That Chiari was causing something that would cause that pressure to be elevated. Another case, 40-year-old woman with frontal headaches and progressive visual loss. Well, sounds familiar. A large blind spot, a lot of papilledema. This is a tough case, but I want to lead you through it because it taught me a lot of lessons, and it's probably not over. We did the same thing. We monitored her pressures. They were normal. We did a Chiari decompression. I'm sorry, I went back. Here's her pictures, okay? Similar to the 9-year-old I just showed you. Because of her vision getting worse, we were so worried about that. She had the vision was much worse than her headaches, but she had daily headaches. They were up in the front, as I said. We did an endoscopic third ventriculostomy on her. Her headaches completely went away. First time for years. I was all excited. She came back. She felt great. Okay? Checked her vision. It was worse. So we failed. Basically, we got her feeling better, but her vision's worse. Did we really benefit her? And there's theories as to maybe why it got worse if you can think through the anatomy. Well, what do we do next? Well, we were so worried about her vision, the ophthalmologists are calling us every day. We decided to put a shunt in. Her vision stabilized. It didn't continue to get worse, but didn't get a whole lot better. Headaches are still gone, and she went on for another couple years, developed recurrent headaches, but now they're more occipital, more classic Chiari-like, which they weren't in the beginning. MRI, pretty much the same, showed the Chiari malformation. Her shunt's in place now. We then decompressed her Chiari. We had to externalize her shunt at the time because there was a question of an infection that came up. And it was interesting timing. So we decompressed the Chiari. I always checked the shunt to make sure it was working. And a couple days later, the shunt showed some sort of bacteria. We were worried I had to pull the shunt out. And then we're wondering, okay, we decompressed the Chiari. Do we need the shunt? Okay? Are you with me on this? This is complicated, but we could not clamp that ventricle off at all. I mean, her headaches would go through the roof. And she felt so good with that ventriculostomy open, that external drain. So we ended up replacing her shunt after the Chiari was decompressed. This woman has felt the best she has felt for her whole life, she told me. She lost 40 pounds. She's exercising 2 hours a day. But how do we get this kind of result? This is unexpected. And what we put her through, endoscopic third ventriculostomy, shunt, Chiari decompression, shunt removal, shunt replacement, that's a long course to go through. And she sure feels it's worth it. I mean, she is a different woman, seeing her. Now, it's very gratifying. I just hope it lasts. But it's been quite several months now. It's almost a year. and her vision rapidly improved, better than it ever was. And I was telling you, remember, how her vision was getting so much worse. But it took both of those to do it. Just a couple more cases, if you could bear with me. Each of these have just a little variation, as you can see, but this is how we face this in the clinic. A 52-year-old pilot, and believe me, he wanted to go back to fly. And this is similar to the Air Force time. And if they got an MRI scan showing a Chiari, it was a problem. Because as you can imagine, F-16 pilot, what are you going to tell them? Oh yeah, I'm sure it wouldn't be a problem if you eject. You know, you'll be fine. You know, we can't even tell someone to go back to play football. But real big issues we have to talk about with them. But this pilot wanted to go back. He had a very tight Chiari, throbbing headaches, neck pain, paresthesias, terrible insomnia. The next speaker is going to talk about sleep, which is a great segue to that. No syrinx, no hydrocephalus. Had multiple CT-guided LPs before he got to me, showing high pressures, dramatic improvement after every tap. The question is, what do you do with him? Well, he really didn't want that Chiari decompression. He was worried FAA was going to throw him out. Really wanted to go back to fly. He could fly with a shunt. You know, we had all these discussions, which you have to individualize this discussion with every patient. This is a very important thing for him. You know, but he has a Chiari. He's got pretty normal-sized ventricles. Okay, we shunted him. Dramatic improvement of his headaches. Neck pain got better. Really doing well. Felt like a good quality of life. He was thinking about how to get back to fly, but this did not get better, his insomnia. And it was severe enough that, you know, he was tired through the day. He just didn't feel like he could get back to fly. So it'd be interesting, you know, talking about sleep, which is a big deal. And I have no way to get this better for him as a neurosurgeon. You know, what can I do, you know, with the shunt in? And he was doing pretty well otherwise, but last month, of course, right before this talk, he'd started developing weakness and paresthesias of his arms. You know, what's going on now with them? And MRI, no change. Of course, we checked for a syrinx. Maybe there's a pre-syrinx, but so far we don't see anything. And we've tracked his MRIs for a long time. I need your help here because I don't know what to do with them. And now I just left Duke and I got problems. So of course, he can fly anywhere for free. He wants to come anywhere he can. But he really has issues of where to go next. And probably it's going to be decompressing his Chiari. Okay? But did we ever have to shunt him? You know, it just haunts me. He has a shunt that maybe he didn't need. Last case, I'm pretty sure you're bearing with me, I'm sorry. 54-year-old developed progressive weakness of his arms and legs, swallowing problems. This sounded like that first kid I showed you. This guy's really having trouble. All right, he's getting worse, bladder incontinence. But be careful, he's got headaches that are always worse when he's up. He sits up, and we thought he was orthostatic, and he has a heart condition, so they blamed it on that for years and never scanned him. You know, here's his MRI scan. He also, it's hard for you to see, but he has a very tight Chiari, a long syrinx, very tight in the foramen magnum. This is here. And he has this condition of very low CSF pressure. And I wanted to end with this because it goes both ways, right? And this is not a patient you want to miss. Every time he would get patched with a blood patch to deal with this leak issue from his spinal fluid problem, he had multiple little holes, probably in a setting of Ehlers-Danlos. He's still being worked up genetically at the NIH. He would get better. His arms would get better. He would start walking again. 3 weeks, 6 to 6 weeks later, he would get worse. These patches would open up. Syrinx would get bigger. And this was documented on imaging. Syrinx better, syrinx worse. Syrinx better, syrinx worse. He just couldn't deal with this anymore. He went on 25 blood patches. But as a quality of life, you can imagine how that works. And he had to go to many different places because people would say, well, 3 blood patches, I'm not doing any more. You know, then he'd be quadriplegic again in a wheelchair. So these are dramatic issues that these people face. We ended up doing a Chiari decompression, and it's the longest he's had now. He hasn't had to have blood patches again. And he's up, he's in rehab. You know, he's doing better, but it's only been about 6 months now. But he was getting this every 3 to 4 weeks. So we've clearly changed the cycle. He was extremely scarred in here. I'm sure Dr. Bausdorf has incredible experience with this. You know, just how scarred they are at their foramen magnum from all this chronic tension of the low pressure. Now, I've talked most of this time about high pressure and pseudotumor. This is the opposite. And you have to tease these two out because they're very, very different conditions. You sure don't want to treat him with a shunt, so you can get into a lot of trouble. So in conclusion, these symptoms overlap tremendously between Chiari and pseudotumor. That eye exam is very helpful. We need to use that eye exam, and every patient I would send to get their eye checked before I would operate on them. I just need more clues. Not necessarily to make the decision and go to surgery, but if they fail later. The more armed we are with data to help us for the failures, I think the better we're going to be able to understand what's happening. I'm still not tapping these people, but we need to just do as much information as we can. Watch out for these positional headache patients and for the failure to resolve symptoms. You do the Chiari, they got better, they then get worse. Think about pseudotumor and the fact that pressure could be haunting them even a couple years down the road. It may be a factor for recurrent failures. So thanks for your time, and I appreciate the opportunity to be here.